Our next session is on major arrhythmias in CICU. We'll be having our moderator, Dr. Anil Kumar. Dr. Anil Kumar is consultant pediatric cardiac ICU at Sir Gangaram Hospital, New Delhi. Yeah. So the chairperson for this session is Dr. Amitabh Chattopadhyay. Sir, please, we welcome you on the dais. Sir is our director and head of the pediatric cardiac unit at Narayana Super Specialty Hospital. And he is the head of the eastern zone of Narayana Hospitals of Pediatric Cardiology. Sir, calling the panelists, or I will call the panelists. I welcome the panelists here. Dr. Devdatta Mukhopadhyay, Dr. Maninder Dhaliwal, Dr. Rishika Mehra, and Dr. Shonjiban Ghosh. Okay, so I will just introduce Dr. Devdatta Mukhopadhyay is a pediatric cardiologist working at Diamond Harbour. No, not this one. Just don't focus. It's not there, I think. So she's the pediatric cardiologist practicing in Kolkata for a long time, and she's a very well-known face of Kolkata. And she's currently attached to Diamond Harbour Hospital. Sorry, BC Roy. Yeah, BC Roy Hospital and Apollo Hospitals, Kolkata. We have Dr. Rishika Mehra. She's attached to Narayana Super Specialty Hospital as a pediatric cardiologist. We have Dr. Maninder, who is there as a pediatric intensivist at Amrita Hospital, Faridabad. Yeah, and we have Dr. Shonjiban Ghosh, who is also with from Narayana Super Specialty in the Department of Pediatric Cardiology. So over to you, Dr. Anil.
Good morning, everyone. Good morning, everyone. Thank you so much for such a nice introduction of all. I welcome respected chairperson and respected panelists, my esteemed colleagues. So, why it is very important to discuss this topic of arrhythmias in children? So, various studies have suggested that around 1/3 of the patients who are admitted in pediatric cardiac ICU may experience at least one episode of any rhythm abnormality, either ill-sustained or sustained during their cardiac ICU stay. And if you talk about the subset of patients who have undergone the cardiac surgery, so the incidence can go up to half, that means 50%. And because of these rhythm abnormalities, there can be chances of prolonging the hospital stay, and sometimes these rhythm abnormalities can be so unremitting that they can also lead to mortality. And mind it, interpreting the ECG of a arrhythmia patients cause more tachycardia in doctor on duty than any other investigations. So, not wasting time, we will discuss this session. Initially, we will discuss about the basic approach and characteristic. Then we will take some major arrhythmias one by one. So, my first question is for Dr. Devdatta. Ma'am, what are the common rhythm abnormalities we usually see in our pediatric cardiac ICUs?
As in pediatric arrhythmias, in the perioperative period, it's the narrow complex tachycardia which predominates, and it also depends on the anatomy as well as the kind of surgery that has been done. For example, the common findings, about 10 to 15% cases will have a junctional ectopic tachycardia, especially in postoperative tetralogies, postoperative atrioventricular septal defects. Also, as the age of the child increases, in adults with operated congenital heart diseases, there will be more incidences of atrial fibrillation flutter, where there has been a lot of surgeries, scars, and incisions over the atria. And we also have VTVF occurring in the immediate postoperative period in cases of post-switch operations and the surgery for the tetralogy operations also. And of course, heart block in wherever the AV node, the region of the AV node has been manipulated, for example, in CCTGA or correction of VSD, etc. There we can have bradyarrhythmias with various levels of heart block. The important thing is that before the surgery, it's very important to get a baseline ECG to know whether there is any pre-existing anomalies, like for example, an Epstein's anomaly may have a pre-existing pre-excitation pattern, delta wave and all. And also, if the child has a pre-existing occurrence of arrhythmias, then it is important to discuss with the electrophysiologist and sort of analyze it so that they can plan out the surgery for a concurrent electrophysiology procedure.
So,
Yeah.
ma'am, is there any group of rhythm abnormalities specific to patients with non-structural heart disease?
Usually, if in neonates and infants, it would be the atrial ectopic tachycardias, sometimes atrial fibrillation also. But those are treated mainly with medications and controlled well with medications. And structural heart diseases would be the ones that are operated, JET and VTVF, etc., which are occurring in children with structural heart diseases. Of course, it depends on the anatomy and the kind of surgery that is done.
Ma'am, one more question. Can sinus tachycardia can also be troublesome sometimes?
Yes, sinus tachycardia can be very, very troublesome because in the immediate post-operative period, it is usually in the first 2 days, 1 or 2 days, immediately post the bypass, the myocardium is still recovering from the injury. So that predisposes it to a lot of a kind of a arrhythmogenic potential and all. And so if the heart function is already in a compromised phase, so even a little bit of tachycardia or tachyarrhythmia can, it can tip the hemodynamic balance off. And since we talk about sinus tachycardia, sometimes ectopic atrial tachycardia becomes very difficult to distinguish from sinus tachycardia, especially the ones where the focus is near the SA node, and it can be difficult to treat in newborns.
Okay. So, as ma'am has already explained, so there can be patients with structural heart disease in the post-operative period, or patients without structural heart diseases, and sometimes sinus tachycardia can also be troublesome. So, next question is for Dr. Rishika. So, what are the basic mechanisms? Can we group these rhythm abnormalities in as per their pathophysiology, just for the sake of better understanding of the management part? So, what are the common mechanisms responsible for these rhythm abnormalities?
So basically, rhythm abnormality mechanisms can be divided into the mechanisms which are related to the impulse generation and the impulse conduction. So impulse generation, those would be one which would be of enhanced automaticity or the triggered activities, and those for the conduction defects would be the our conduction blocks or the reentrant tachycardias. So reentrant tachycardias would include our AVRTs and AVNRTs, and the other groups which are the impulse generation ones, those would include the enhanced activities, which would include mostly the junctional ectopic tachycardias or ectopic atrial tachycardias. And the triggered activities are a different group which would include the early after depolarization or the late after depolarization kind of defects. So there are subtle differences between ones which have the enhanced automaticity and ones which have the reentrant kind of the mechanisms. So the reentrant ones have an abrupt onset and abrupt offset. They do not have a warm up and cool down phase, and they can be terminated via our pacing mechanisms. However, the reentrant ones are mostly incessant kind of, and the pacing doesn't work more in them. And there are kind of AV dissociation more in our reentrant ones.
Okay. So, to summarize, there may be basically two mechanisms. One is re-entry and one is automatic mechanism. So, reentrant tachycardia has an abrupt onset and termination, and they are more sensitive to adenosine and external extra stimulus, while automatic tachycardias are basically unremitting, and they are less sensitive to adenosine and cardioversion. So,
in fact, in the post-operative scenario, in fact, these triggering activities, you are creating more and more triggering factors, places where they can create more and more arrhythmias. So, obviously, the patient is susceptible to more and more arrhythmias.
Thank you, sir. Coming on to the next question to Dr. Maninder. Sir, what is the basic approach for these fast rhythm patients? How do we approach patient with this fast rhythm?
So whenever we see a tachyarrhythmias, so we have to clinically correlate, not just focus on the ECG part. So whenever tachycardia clinically correlate whether the patient is stable or hemodynamically unstable. So if the patient is hemodynamically unstable, how you define it? It's basically a patient has got altered sensorium, or the CFT is delayed, or there is hypotension. Then you basically divide it into a wide complex or a narrow complex tachycardia. So if it is a narrow complex tachycardia, then according to the age, you have to define the QRS pattern. So if the QRS is as you can see in the screen, so if the QRS duration is less than 0.09 seconds, that is 2.5 squares, then you can possibly think that this is basically an SVT. If the QRS complex is wide, then you can think this as a VT. So first, most important is whether there is a cardiovascular compromise. And this is just to show you how a fast rhythm can look like. You don't have to be a cardiologist or an electrophysiologist to interpret this. So whenever this rhythm happens, either it can be the mountains that are there, that is the wide QRS, that is ventricular tachycardia, or the narrow complex, that can be either SVT or jet, or it can be sinus tachycardia, that the further interpretation will help you. So if it is the one where you get narrow complex, it's a probable SVT, and the patient is hemodynamically unstable, then the treatment will be synchronized cardioversion. But if synchronized cardioversion is taking time, then you can give adenosine by that time. And if the patient is actually stable, so then you can give vagal maneuvers followed by the adenosine in the case of SVT. But if it is unstable VT, then would be synchronized cardioversion, whereas a stable VT, you will give adenosine, and it's still not resolving. Then for VT, it's better not to tamper with the patient much. If it is stable, call a cardiologist. They will tell you what to do with it.
Dr. Maninder, can there be some clues in ECGs to further differentiate the fast rhythms? What kind of rhythm to help in the management part?
So if the patients are stable, so this is for unstable patients, quickly you can diagnose and save a child. But if the patient is stable, then it's better to go for a 12-lead system where there are 3 bipolars, 3 unipolars, and 6 chest leads. And then you go step by step. So whenever you have taken the lead, you have done the calibration, take a pen and paper, calculate the heart rate, then see whether it is regular. Regular is every QRS, RR is regular, and P is preceded in every QRS. Then you look at whether it is regularly irregular. Any abnormal rhythm which is regularly repeating, or if the RR is not regular and P waves are also not there, you're not able to recognize, and it's basically atrial fibrillation. Then you go for the axis. So step by step, you have to see lead 1 and AVF and see its left axis or right axis. Then again QRS morphology. And then ST and T will basically tell you about myocardial injuries, and T will tell you about the electrolyte abnormalities. This is a basic
ECG interpretation. Thank you, sir. So the most important step to assess the hemodynamic stability of these patients, this just bifurcates the management or in the stable limb and the unstable limb. So this is the basic approach to a patient with fast rhythm. So Dr. Sanjeevan, are there any other modalities which we can use in a pediatric cardiac ICUs which help in the diagnosis as well as the management of these patients with fast rhythms?
Yes, as Dr. Maninder already told, the mainstay of diagnosis is the 12-lead ECG. So by looking at the 12-lead ECG, if we can pinpoint the diagnosis, the management will be much easier. There are other few modalities which can be used, particularly in post-operative intensive care unit. The most important is the AWARE study. So what is AWARE?
So what is AWARE? In a post-operative child, if it is an open heart surgery, the surgeon will put a atrial wear and a ventricular wear. This is for the temporary pacing. So this atrial wear is known as AWARE, and apart from the therapeutic value, this AWARE has immense diagnostic value. So what is AWARE study? Like a conventional 12-lead ECG, this AWARE can be put in a particular lead. Conventionally, we put it in either in V1 or V2. And what will be the result? The atrial activity will be amplified. And this is having an immense importance. Why? Because in particularly tachycardia ECG, it's very difficult to find out the P wave, because sometimes it get merged inside the QRS complex, sometimes it can be merged with the T wave. So getting the P wave is very difficult, but if you do a where ECG, you can see the example here. So this is a sinus rhythm. The P wave is nicely seen in the ECG, in the first ECG. The lower down, this is the atrial ECG, where you can see the P wave is amplified in this lead. This is the P wave, which is the atrial activity, which is amplified. And in a particular tachycardia ECG, if the P wave is not seen, by looking at the A wave ECG, you can identify the atrial activity, and the whole diagnosis is based upon the atrial and the ventricular activities. What is the number of ventricular activity? What is the number of atrial activity? What is the relationship between the atria and the ventricular activity? Whether it's a retrogradely conducted atrial activity, whether it is every time it is preceded by the ventricular activity or not, and what is the AV interval, what is the VA interval. Based upon that, you can classify this as a short RP, long RP tachycardias. So it will have an immense importance on the diagnosis. This is the AWARE study. Another one important thing I would like to highlight is role of adenosine. We all know there is an excellent therapeutic role of adenosine, particularly in a re-entry tachycardia. But apart from that, adenosine is having an immense importance in diagnosis. What adenosine does, it actually blocks the AV node. So the ventricular conduction gets minimized. And in that particular condition, suppose a atrial flutter or fibrillation, it will never get terminated by giving an adenosine, but the atrial activity will get unmasked. So as you can see here, can you play it from the very beginning? So this is a narrow QRS complex regular tachycardia. We are pushing adenosine. You can see the ventricular activity has come down and the atrial activity got unmasked. Now you can appreciate the flutter waves. So it was a case of atrial flutter. So by pushing adenosine, you have immense diagnostic value. And another one important thing I would like to highlight is the rapid atrial pacing. This is having diagnostic as well as therapeutic value. How rapid atrial, again, this particular modality is only for the patient who is having a atrial wear, like for the pacing. So you cannot apply this for a patient who is not having a temporary pacing lead in the atria. So suppose in a post-operative patient who is having a atrial wear, you can connect it with the temporary pacing box and you can start rapid atrial pacing. Suppose you are dealing with a patient with a re-entry. So what will happen after doing a rapid atrial pacing? The electrical impulse will get entered inside the re-entry circuit. It will terminate the re-entry, and then the patient can have a sinus rhythm. So what is happening here? There is a doctor. Can you please start it from the very beginning? So it's a narrow QRS complex tachycardia with around 200 heart rate. Now we are starting a rapid atrial pacing at a rate of 210, which is higher than the tachycardia rate. So we have started pacing the patient at 210. So as you can see, the heart rate went up to 210 because of the pacing. Now when we stop the pacing, now you can see the heart rate has come down to 150 and the hemodynamics is much better. Sometimes it's very difficult to terminate the rhythm. Suppose a patient is having a atrial flutter or atrial fibrillation at a rate of 250. So the ventricular rate, if there is a 1:1 conduction, the ventricular rate will also be 250. And if the ventricular rate is this first, the cardiac output will be very less. So the patient will be hemodynamically compromised. Suppose in this particular patient, we are having an atrial wear and we have started pacing the atria at a much higher rate. Suppose 100 beats per minute more than the basic rate. So suppose we have started pacing at 350. At a very high rate, there will be a rate-related AV block. So if you can achieve a 2:1 AV block at a rate of 350, then the ventricular rate will be 175. So initial arrhythmia rate was 250. Now you have achieved a rate of 175 for a ventricle. So ventricular contraction will be much better. So the cardiac output will be improving. And simultaneously at this particular time, you can start the pharmacological therapies like a beta blocker or a amiodarone at a very high dose. So you can control the rate. So you are pacing, so you don't have a fear of bradycardia, and simultaneously you can have you can terminate the tachycardia. So one modality is A-wire pacing, which is underutilized but immensely important. Next is the role of adenosine, which can be applied in normal pediatric ICU also. And if you have a A-wire, then you can start rapid atrial pacing.
Thank you, Dr. Sanjeevan. Yes, atrial wires are very, very important in post-operative cardiac patients. So A-wire study can be help in establishing the peak QRS relationship in tachyarrhythmias as well as bradyarrhythmias also. So, so starting from the first common arrhythmia is PSVT. Dr. Devdatta, what is the approach in these patients of PSVTs?
Not much left for me to say because Dr. Sanjeevan has very beautifully explained the entire thing. Just a few important points to highlight that most of the PSVTs, number one, they will have a paroxysmal onset and offset as well, post adenosine. Within 1 or 2 beats, the change from the SVT to the sinus beat will come. So that transition is very important to record. And all these are post-giving adenosine, the entire street must be documented because it helps us to diagnose what is the cause of the PSVT. Almost 80 to 90% of the PSVTs will be re-entry. So that mode of re-entry can also be diagnosed because usually, even though there is no obvious P wave preceding the QRS complexes, most of the re-entries may have a kind of a P wave, abnormal P wave, retrograde P wave hidden in the QRS post the QRS complexes. So if we can show the ECGs. So when there is a AV nodal reentrant tachycardia, then because the reentrant pathway is conducting retrograde, so the P wave will be a retrograde P wave hidden a little away from the QRS complex. And that would lead to a short RP tachycardia. And if it is a AV reentrant pathway in an accessory pathway, then it will be a long RP tachycardia. Like here you can see, if you can point out the P waves sort of coming retrograde quite away from the QRS complex, but preceding the next QRS complex. So this is the long RP tachycardia. That is the retrograde P wave actually, which is coming much away from the QRS complex. So it's a long RP tachycardia.
So they are traveling towards the atrium by the slow pathway.
By the slow pathway in the accessory path. And sometimes we also have the PJRT or the paroxysmal junctional retrograde pathway.
Is there any difference in the management part of these long RP and short RP? Yes,
we would like to start on beta blockers definitely, and also they would need, sometimes we might need to start calcium channel blockers in addition to it, and also we would need an opinion of the electrophysiologist if it is very recurrent and if it is refractory to the pharmacological therapy, and we need to ablate the pathways.
This is the response of adenosine is. So we can see as soon as adenosine is pushed, there is a reversion of the sinus to the sinus rhythm. So Dr. Devdatta, suppose there is a patient who is not responding to adenosine. So what are the options for the medications?
Definitely after the highest dose of adenosine, we would usually in our unit we would start a beta blocker infusion, and we would try to sort of make the child hemodynamically stable, and if the child is not hemodynamically stable, then as Dr. Dhaliwal had explained, we would go for a synchronized cardioversion.
Amiodarone infusion in pediatric patients?
If hemodynamically stable, sometimes we can use them. Yes.
Okay. So
post-operative patients, that whether amiodarone would lead to ventricular dysfunction more than the creation of blocks and all. But in actually the papers, they say most of them they do not cause any dysfunction. There is one worry that whether amiodarone cause more dysfunction, but in actuality the dysfunction doesn't occur. The papers say the dysfunction is not that much. In most of the cases, dysfunction doesn't occur. You can use amiodarone.
So I think depends on loading. Some
Depending on the loadings.
Like
Like
after loading
the
of
5
amiodarone,
milligram,
usually the
and the
dysfunction will
worst
occur.
part is that if the loading is done too quickly, then there is a chance of an irreversible block, which we should avoid at any moments. Like some schools of thought, like Shubhadeep does, that instead of 5 milligram per kilo over a span of time, you can divide it into 5 parts, 1, 1, 1, 1, 1. Anything which works.
So slow loading can be done, basically. Slow loading. Next question is to Dr. Maninder. So what is the approach for the unstable PSVT, and what are the important points which we should keep in our mind while doing the cardioversion?
So SVT is again not uncommon in medical ICUs. So it's almost a very common arrhythmia in medical ICUs also, like myocarditis and other places. So everybody should know that after adenosine has failed or the patient is unstable SVT, then you can directly go for synchronized cardioversion. Now the points that are missed usually, or we should highlight, are that once you're doing a synchronized cardioversion, the ECG leads of the defibrillator should be attached to the patient, or the paddles have to be made such that they synchronize with the patient, not the monitor. But the defibrillator monitor should be connected to the patient. Then because if the patient is breathing spontaneously, has more pain, and you're going to give a shock, then it's better to sedate a bit. So little dose of midazolam. And then the dosage would be 0.5 joule per kg, a lower dose. And most important thing is you have to switch the sync button. So if you don't switch on the sync button, then it will not be right. Then it will give a shock. So this is a small video representing the same. So the patient is being attached, the monitor is coming there. You calculate the dose, 0.5 joule per kg. The patient is little sedated. Apply the jelly, charge the pedals, and you can give a charge from here, or you can give a charge from the defibrillator machine. After giving the charge, you can see the rhythm has reverted.
So yes, definitely there should be the synchronization to prevent the RNT phenomena that can lead to ventricular tachycardia. So so this is the rhythm strip of this defibrillation. As we can see that initially there is a narrow QRS fast rhythm, then immediately after there is a cardioversion of 5 joule, it reverts to the sinus rhythm. So coming to the next set of supraventricular tachycardias, atrial flutter and fibrillations. Dr. Sanjeevan, although these are very less common, but what is your experience? How frequent is atrial flutter and atrial fibrillation in pediatric cardiac ICU?
Yes, you correctly told. It's in a structurally normal heart, atrial flutter and fibrillation in pediatric population is extremely rare. Probably it's much more common in fetal life. Fetal atrial tachycardia is well described. So probably atrial flutter is common in NICUs. So a particular neonate born with a very fast heart rate, atrial flutter is common. And these atrial flutters respond excellent to the cardioversion, and usually they don't recur. But in post-operative cardiac ICU, particularly if you are dealing with a child with congenital MR, congenital MS, or a juvenile rheumatic mitral stenosis with hugely dilated left atrium, they can have atrial flutter and fibrillation. Again, atrial surgeries like a Senning or a TAPVC repair during immediate postoperative or during follow-up, they can have atrial flutter and fibrillation. So for a postoperative ICU, atrial flutter fibrillation is not that rare. But yes, in a structurally normal heart in pediatric population, it's rare.
So what is the basic points to approach atrial flutter and fibrillation?
Yes, in the approach first, the diagnosis. We have to diagnose the rhythm first. Majority of the time, they will be hemodynamically stable, so you will have the opportunity to take a 12 lead ECG. Atrial flutter, usually it's a narrow QRS, regular tachycardia. Sometimes it can present with fixed AV block or a varying degree AV block. There you can, I already mentioned about the diagnostic value of adenosine. So if you give adenosine, the ventricular activity will be reduced and the atrial activity will be unmasked. As you can see in the first ECG, it's a regular narrow QRS complex tachycardia. You have given adenosine there, so the ventricular activity is much less. Now you can see the atrial activity. These are the flutter waves, so you can diagnose. And atrial fibrillation is usually a varying heart rate. The ventricular rate will be varying. So it's an irregular tachycardia, it's not a regular tachycardia. So after diagnosis, you have to manage the patient. There are three pillars of management. One is the control the ventricular rate, which is very, very important. If the ventricular rate is very high, the patient will be hemodynamically unstable. So you have to control the ventricular rate. That is very important. So what are the drugs we can use? We can give beta blockers, calcium channel blockers, or we can use digoxin. Dexmedetomidine is having adjunctive role. And next is the control the rhythm, to make the rhythm sinus. There are two types of atrial flutter fibrillation. One is chronic, where achieving a sinus rhythm is extremely difficult. But if it is an acute atrial flutter or fibrillation, suppose you have taken a patient for a ASD device closure, there is some injury to the atria and the patient is having a atrial flutter in the cath lab. So it's an acute atrial flutter. So you can achieve a sinus rhythm. Either you go for a synchronized cardioversion or you can give drugs like amiodarone. So there you can achieve a control of the rhythm. And but before giving a shock cardioversion, you have to ensure that there is no clot in the LA, because atrial flutter and fibrillation can have thromboembolic phenomena and there can be atrial clots, particularly in the left atrial appendage. Before giving a cardioversion, you ensure that there is no clot, because if there is a clot in the left atrial appendage, that can have a systemic embolization. And the third important step is prevention of the thromboembolism. So if the patient is having atrial flutter, you have controlled the ventricular rate. Now you have to put them on some anticoagulants if they are high risk for a thromboembolism. We have several scoring systems to assess the risk of thromboembolism. The commonly used scores are Chadva score and the Hasbled score. We usually follow the Chadva score. C stands for congestive heart failure, H for hypertension, S for stroke, V for vascular malformations, A for age more than 75 years, S for sex. So in pediatric population, usually they are low risk for thromboembolism. So we can skip the anticoagulation. But if it is an adult patient and if the score is more than 2, we have to put either warfarin or oral NOACs like dabigatran or apixaban.
Thank you, Dr. Sanjeevan. Yes, flutter and fibrillations, atrial flutter and fibrillations are less common in pediatric age group, and they are relatively more common in post-operative patients where atrial surgeries are being done. So moving away from the atria and coming to the junction, Dr. Maninder, junctional ectopic tachycardia, what are the common lesions associated with these kind of junctional tachycardia?
So the name itself suggests that it starts at a junction, AV junction, and there's an ectopic focus which is happening and it's causing a narrow complex tachycardia. So this is one of the most malignant arrhythmias that you can see in a post-op cardiac ICU. And if it is not controlled, then this can actually lead to a mortality also. So recognition and intervention becomes very, very essential over here. And mostly seen with post-op patients like post-op patients and AVST, where they actually fiddle around with near the AV junction. And sometimes new trainees come, so the jets usually happen more in cardiac surgery. That is just a off point that I'm telling you.
Yes, actually this is a most common tachycardia in the post-operative subset in the children. So yes, it's a narrow complex tachycardia, sometimes unremitting, difficult to control. So next question is for Dr. Rishika. How to differentiate this narrow complex tachycardia with other narrow complex tachycardia? How to identify the rhythm?
So as it is already told that jet is basically an automatic tachycardia which is originating from the AV node. So this kind of tachycardia has a fast offset and fast onset, and the ventricular rate is more than the atrial rate. We can sometimes see the P wave, sometimes we cannot see the P wave. in this kind of tachycardia. So the AY study becomes kind of important to diagnose our JET. So though in the 12-lead ECG, the P waves cannot be seen a lot of times, but as about the AY study, as it had already been told that the atrial wires would be attached either to the V1 or to the V2. So in that, the atrial kick or the atrial spikes are visible. So that helps us in diagnosing whether it is a JET or whether it is a normal supraventricular tachycardia, because sometimes in a JET also there is a 1:1 AV conduction kind of thing. However, mostly it is an AV dissociation kind of tachycardia, but to differentiate it, the AY study becomes important. Also, we have to see the hemodynamic monitors as we go along with the JET, because the atria will, if there is an AV dissociation, there is a loss of atrial kick and the atria will contract against the closed AV valve. So here we can see that as a junctional rhythm is going on, and we can see the CVP trace. So whenever the atria is contracting against the closed AV valve, there are large giant A waves which are seen, and in that scenario the hypotension will occur, as which is visible in this. So when here it is 69/38, the hypotension occurs and the patient goes into a low cardiac output state. So that's why these incessant kinds of JET becomes problematic to us in the post-operative period, because there is a loss of decrease in the cardiac output and hypotension which takes place. Also, JETs are sometimes seen even in there is a modality called a congenital JET, which is a very rare modality, which is seen only in less than 1% of the infants in less than 6 months of age, but that is a very troublesome, incessant kind of tachycardia and causes high mortality in around 35% of patients. So in our post-operative JETs, as it was discussed, it is mostly related to, it occurs in first 7 days and mostly in first 24 to 48 hours of the post-operative period, relating to the cross-clamp time and the surgeries which have mingled with around the AV node, like the tetralogy repair surgeries and the AVHD kind of surgeries.
What is the basic target while the patient is experiencing this tachycardia? What is the target for the...
So basic target, there would be two kind of things. First, we have to hemodynamically stabilize the patient, and what can be done is, first we have to decrease the rate, because mostly these kinds of JETs have more than 170 kind of heart rate. So one of the target is to decrease our heart rate, and second target is to achieve the AV synchrony. So to decrease the heart rate, because these kinds of patients, as they are hemodynamically unstable, so they are under a lot of support of adrenaline, noradrenaline, vasopressin, etc. So those consume a lot of myocardial oxygenation. So we have to try to decrease upon the vasopressor supports. Also there is a algorithm in which we'll try to first of all decrease the core temperature, that would be around 33 to 35 degree, and we'll try to maintain the electrolyte balance, that will be the magnesium, we'll try to keep serum magnesiums more than 2 millimole, calciums more than 1.2 millimole, potassium more than 4 millimole, and then if that also doesn't control our rates, we can further start with IV amiodarone, which can be according to the institutional protocol, as like we can load, or it would be better as sir practices in our unit, that 1 in 5 aliquots it is given. Also there is a if the rate is around 150 or it is around less than 170, also an atrial pacing can be done, which will be around more than 10 of the rate of the child which is going on. That would help re-establish the AV synchrony and help regaining the cardiac output and decrease the hypotension.
So, okay, thank you. So first, to summarize, the first aim is to decrease the heart rate, either by decreasing catecholamines, which is very difficult in critical patients, or either achieving hypothermia to a certain limit, and or either by using amiodarone, and then to sequential pacing in to achieve the AV synchrony. As we can see in this image, there is a Canon waves in this CVP trace, And there is a, when these waves appear, there is a loss of synchrony, and the systolic BP falls from 74 to 69. So basically, there is a loss of synchrony on higher rates. So that's why patients land in low cardiac output. So.
Just one word about the jet. There has been some studies on giving magnesium infusion in the fluid during the rewarming phase of the cardiopulmonary bypass. So that sort of has shown that it has decreased the incidence of jet in the post-operative period.
Thank you, Dr. Deb. So coming on to ventricular tachycardias, Dr. Sanjeevan, what are the common causes of VT in ICUs, and what is the common approach for these patients?
So common causes of VT, particularly in a structurally normal heart, there can be channelopathies like long QT syndrome, Brugada syndrome, CPVT. In teenagers, fascicular VT is common.
Can we briefly summarize it? Time
Yeah, okay. So, structurally abnormal heart like a hypertrophic cardiomyopathy, ARVD, arrhythmogenic right ventricular dysplasia. And in postoperative ICU, because of myocardial edema, particularly after surgeries, if the patient is on a very high dose of inotropes, they can have VTs, and post-myocarditis, post-MISC, VTs are common. So how to approach? First, we have to see whether the patient is hemodynamically stable or not.
Same.
If the patient is hemodynamically unstable, straight away go for a synchronized cardioversion. If the patient is hemodynamically stable, then get a 12 lead ECG. That is the protocol for all the tachyarrhythmias. And then it will be a white QRS complex tachycardia. You have to differentiate it with a SVT with aberrancy. So you have multiple algorithms like a Brugada protocol or a Verikis protocol, by applying which you can diagnose the ventricular tachycardia. Management, first the antiarrhythmics, the commonly used drug is the lidocaine. That will give you a sinus rhythm. Then amiodarone can be used, and definitely for a long-term management, beta blockers, calcium channel blockers can be used. So if we look at these ECGs, can we play this?
Yes.
Okay, so here you can see during the sinus rhythm the blood pressure is much better, 84/40. So now there is a VT. So as you can see, there is a drop in the blood pressure. So when the ventricular rate is very fast, at that time there is a loss of cardiac output.
Thank you, Dr. Sanjeevan. My next question is to Dr. Rishika. Can you briefly summarize bradyarrhythmias and what is the approach in preoperative as well as postoperative patients?
So though bradyarrhythmias is a very big topic,
Very big topic.
so here I would just like to briefly we can have two types of mechanisms, one which are relating to the sinus node itself, or the others which are related to the AV nodes. So first, like in the first ECG which we can see, it is the sinus node kind of a problem. So sinus node kind of bradyarrhythmias can basically be just sinus bradycardias, or they can be sinus arrest or sinus pauses themselves. And in the AV node kind of, we can have type 1, Mobitz type 2, or we can have the third degree heart blocks. Also, we can have complete heart blocks. So in Mobitz type 1, we know that it is like the PR interval is fixed, but it is prolonged kind of. In the first degree heart block, the PR interval is mostly more than 200 milliseconds, but in Mobitz type 1 kind of, so the PR interval will gradually increase till the one of the P is lost and the next rhythm starts. And in the Mobitz type 2 kind of block, we have the fixed PR interval. There will be group beating in Mobitz type 2 kind of heart.
So when to treat
So,
low rhythm?
So basically, it's not just the heart rate which determines when to treat these patients. It basically, the symptoms basically determine when to treat these kinds of patients. So when the patient has hypotension, decreased cardiac output, if it is a bigger patient, he will complain of syncopal kind of or dizziness kind of things. That would help to determine treatment.
Post-operative patients who have transient complete heart block or junction, how long you wait to
So in
for the permanent pacemaker?
So in like there have been guidelines like in 2021 the PACES has put up their guidelines. We'll wait for 7 to 10 days to for installing a permanent pacemaker, because mostly those are transient kind of things which are caused due to the edema or due to the effect on the junction. So 7 to 10 days wait will be a right method before putting on a permanent pacemaker.
Okay. So this last discussion, patient apnea not responsive with no pulses. What rhythms can we see in monitor?
So these are like arrest rhythms. So there are 4 arrest rhythms. You have ventricular fibrillation and pulseless ventricular tachycardia. So here you will get no central pulses and you get this type of rhythms. These are shockable rhythms. So here the intervention will become DC cardio shock. So 2 joules per kg you have to be given. Whereas the 2 other ones, that is asystole and the PEA, the one in the pink, they are basically not shockable rhythms. Here you have to continue your CPR and CPR epi and look for H's and T's. So the only point that we want to highlight is don't keep on looking at the monitor only, because sometimes you keep on looking at the monitor and there's a return of the organized activity, but there's no pulse. That is PA. That is electromechanical dissociation that has taken place. So do not just stop looking at the monitor. Look for a central pulse to stop your CPR for return of spontaneous circulation. Thank you.
Thank you, Dr. Maninder. Just to summarize this discussion, the most important step is to assess the hemodynamic stability while approaching any kind of rhythm abnormalities. If patient is stable, take a deep breath, you have a time. While in unstable patients, go for cardioversion or the CPR algorithm. So it's better to see the patient rather than rhythm. So we should not treat the ECG, we should treat the patient only. Thank you so much for listening, and if there are any questions for our panelists, we are happy to answer.
I don't think so. Nobody will ask anybody on the ECG.
Thank you very much, everyone.
Thank you. Thank you everyone for the wonderful session. I would like to request chairperson, the panelists and moderator to please collect the mementos from the registration counter.